All right. If you give me just a moment. Okay, if you think of something or you have a comment for me, please stick it in the chat. We have a person here, bless her heart, she's been working hard for 2 days. We'll get that and get it to us, and we'll be glad to try to respond. Okay, shall I keep on going on? All right, we're going to move on. Can't believe it, I have time. That's not unusual for me, but we're going to move on. Okay, so we're going to move on to our next topic, and it's the principles of effective communication. And I actually have a couple of polling questions. All right, the first one, let's see, is it up? Yeah, we're up. Which of the following statements would be an example of an effective communication? Okay. Well, I guess I can just pack up and go home. No, I see. We're changing a little bit. I better give it a little more time, huh? Before I get all excited. The picture there was of my little kitty cat, who is a feral cat, really, was brought in. So it's amazing that I was able to get her picture. Okay. Actually, you did very well, everybody. So you should be in here helping me do this talk, but we were going to do it anyway. Let's do the next question. All right. Behavior change is based upon a person's what? Physical health, education level, race, willingness to change. I'll give you just a couple more moments here. Okay. Again, y'all did great. This is an important point. We're going to hear about it, but all right. Put my glasses on. I can see. All right. I don't mean to, hopefully don't offend anyone. In looking at those of you that are out there today, there's many nurses, some social workers, not too many community health workers that I saw, but I haven't looked at the list specifically yet. But I'm sure all of you are very adept at communication. But we felt it was important to at least have a session on it to talk about it. So I'm trying to pull from a vast body of knowledge about communication. And this is changing. And we're going to talk about that some, I believe it's tomorrow when Ben is going to come join us on this. But, I did that, I'm sorry. But isn't communication the basis of all care? I love this picture, y'all, by the way. I don't know whether the young man has sickle cell or not, but he certainly is adorable. You know, we can't function without effective communication. Our professions are based on being able to effectively communicate with the population we are working with. And therefore, we felt compelled that we need to at least stop, take a deep breath, and let's think about communication in general. Now, there's people who go to school and study this, and communication theory, and I've done some of that, I've had courses in it, all right? So, and those of you that are professionals, you've had sessions on it, and lectures, and you may have even been drilled by a professor, so, but let's at least talk about some of these frameworks. And that's what's important. If you were setting up a curriculum or a program to train and bring community health workers into the fold, you don't necessarily have to teach this to them particularly, but you do need to think about this as some of your theoretical frameworks. Health belief model, behavior change theory, or what you'll see as the trans-theoretical model, or general communication theory. If I was teaching brand new entry-level community health workers, we would probably, or in my world, my ideal world, would be to spend a whole morning on the health belief model, and another afternoon on behavior change, and then maybe a whole another morning on just general communication. But I would be using adult learning theory, and I would be doing lots of things to be very interactive, and it would be fun, and we'd be laughing and talking, and I'd have hats and all kinds of things going on. Because adults have to learn based on what they already know, and it's important to them. And you don't have to be an older adult to appreciate that. And then in today's world, we'd have to really be thinking about how do we use social media and how do we use the internet and all that. So that's kind of what I want to just go over, a few basic thoughts here. The health belief model has not been talked about as much lately, but I don't know why. Because to me, I got all the way through nursing school and never really knew about the health belief model. Is when I hit public health. And it was like, whoa! But it makes so much sense. And this model has been tested, by the way. It has been revised slightly and has been used in something like, 50 studies, okay? It's not just somebody's thought on the matter. It's actually a tested theory of when we're applying human behavior theory to health behavior, okay? So let's just walk through. This is the MABE simplified version of this model, by the way, okay? That's why it doesn't have a reference on it, because I've made it up based on lots of other reading and really have brought it down to these are the critical concepts. There has to be a threat. And of that threat can be impacted by our socio-demographics. We've talked about that the last 2 days, lots of things. And there has to be an expectation. Let's use our example. The patient, our sickle cell patient is at home and they're having pain, all right? That's a threat, isn't it not? It's a biological threat. It's a threat to their function. I'm hurting so bad, I can't get to work, I can't do what I need to do, I can't take my child, that's a threat. So all those things we've talked about the last 2 days are part of those social demographic dynamics are going to impact our expectation. I'm going to the ER. The expectation is I'm going to get some help there, that's why I'm going to go. If there's no expectation that I'm going to get any help there, is that person going to go? No. All right, so that whole idea, this is what the health belief model is all about, is the idea of the threat and the expectation and then what the action's going to be. And the factors that impact that action are all those things we've been talking about for 2 days. The socioeconomics, the racism, the bias, the severity of the illness, all of that impacts action. So to really bring down that whole health belief model to one little slide, but that's kind of what it's all about. And so we as healthcare professionals, we figure out where in this model we could intervene. And once I started seeing that from a public health perspective, it's like, oh, okay, this does make sense, doesn't it? So it's a tool to predict human behavior. It's based on a person's willingness to change. So thank you, you're very good out there. And a very important piece is the person must believe that change or there's something that's going to happen that's going to help them. And that's a real critical piece. They've got to have faith that something's going to be. So as I said, it's been used for over 50 years with some very favorable studies. And so it makes sense. Earlier, and then in that, all that culture. So our summary of culture concepts, which comes from our first session this morning, is I just put up here just to help remind me that we all have this information, this knowledge in our brains. But culture is going to impact big time whether that person's going to be willing to change, or is it something that's going to be resistance to it, or is their culture, oh yeah, I need to go to the doctor because doctors help me. I go to the ER, man, I get fixed up, okay? But the culture is learned through language and living in their grouping. And it's socialized. So we learn our culture as we grow up. As Keith, I keep thinking of Keith because we just talked about Keith this morning, Keith's story. He's had 30 plus years of developing his culture of where he is in managing his sickle cell. And what we defined earlier this morning, there was some pretty negative kind of things that he has learned, and it's not helping us. Now, the trans-theoretical model, which I know everybody has heard, has to do with the different phases that we go through to change, the contemplative and being ready to change, and you got to be ready. You might want to change, but you just can't do it, all right? How many of us have been down that road? We've all been down that road. Something as simple as you've gone to the dentist and they say, oh, you know, Joan, you got to do a better job of flossing your teeth. You got all this plaque here and I have to do all this work. And I'm like, oh, okay. Something that simple takes, usually the literature says it may take up to 18 different tries to get there. It can take years, it can take months, it can take days. So a simple psychomotor skill, which seems pretty easy. Hey, you need to floss your teeth, you know, in the morning and at bedtime. But there's so many things that interfere with that. And we can want it all we want, but we gotta do something to get there. So the trans-theoretical model or behavior change theory is really critical to a lot of what we're doing. If you're the nurse practitioner in clinic and that patient's sitting there and facing you, and you've gone over with this patient 15 different times about taking their hydroxyurea, well, unless we break it down and figure out what's going on in that patient's life, they may or may not. Remember, Dr. Lopato talked about how some of these drugs come and the packaging and all that has big implications about whether or not that patient can adhere to that regime. And I'm sure all of you have been down this road, haven't you? So behavior change theory is what underlines that. All right, so let's talk a little bit about just general communication. It's so basic to everything we do in our worlds. But it's a cycle, isn't it? See, this is basic communication theory here, that you've got, it's everything we do. While I'm sitting here, I'm running my mouth, it's going out, you're receiving it, and depending on all those things we've talked about will depend on what you're actually hearing and what you're receiving. You may be more interested in what your doggie's doing as opposed to what I'm saying, who's sitting there by you in your study. You know, there's so many things that go on, but it's very cyclic. So it just keeps rolling along. It's a dynamic, it is not static, and it's multiplied or impacted by multiple activities. And we all know that, from as simple as we may be sitting in our family room watching TV. We may be knitting or reading the newspaper, but we're watching what's going on, but yet the husband's over there talking, and we're still listening to him and responding to him. Oh, okay, honey, all right. You know, a lot of things going on constantly. So everything is overlapping in communication theory, and it's all based on, and y'all have had a lot of this, and because most of you have been through trainings where you've learned about the verbal behaviors versus the nonverbal behaviors. I can sit here and go, well, you go, okay, Joan, we don't know anything. What goes on here and happens has major impact on what the message actually is, and so a lot of different things. So concept of communication, you've heard, all of you have heard this, but let's just review it just so that we are on the same page. Active listening. You've heard that term, haven't you? It's how well we listen has a major impact on the effectiveness of our care. What do we see in this photo here? We see the patient is talking. The provider there, she is actively listening. And how do we know that? We're not even watching it and we can tell. She's bending in toward the patient. She's seeking eye contact. She's got a pleasant smile on her face. And I think you can even tell she might even be touching his arm. So there's a lot of nonverbal that we can even see in this lovely picture that shows us active listening going on. And many of you, I know probably most of you, have learned these techniques. You have learned to be an active listener. This is one of my favorite. I don't know if any of you know about Stephen Covey. He was a real big thing at one time, going all over different organizations across the country and doing his thing about how to make your organization better. But as he said, most people do not listen with the intent to understand. They listen with the intent to reply. How many of you have been in a situation like that? I'm sure you have. You're there and people are talking and you're listening, but all you can think about is what you're going to say next instead of really listening. The picture before, I think she was truly listening. So active listening is a critical component of effective communication. Listening takes practice, time, and patience. I know you've heard the term pregnant pause or silence is golden. Well, that can be very important, especially when we're interacting with our patients. We should listen with all of our senses. We're looking, we're smelling, we are listening. We're using every sense that we could possibly use. And I think with the COVID and doing a lot of telehealth, I know from some of my friends that are in my generation, we're older, we're okay with it, but we miss some of that other piece that flat screen just doesn't do. You know, we're missing some of that part, but that doesn't mean it can't be effective, because it can be very effective, and it is nice sometimes when you have your visit and you can go turn on the machine in your PJs and go talk to your doctor and do what you need to do, because that particular visit you don't need. I heard we have a dentist in town that's advertising he can do the monitoring of braces in kids without going to the office. I'm like, now how is he doing that? You know, I don't know. But anyway, because when I had braces, I had to go and you had to look and turn and do all that stuff. But, you know, maybe technology is different. But anyway, active listening. When we actively listen, and we don't do this necessarily 100% of the time, absolutely not. And our friends or whatever, we listen and we kind of listen. But if we're with our patients, we need to make a point to actively listen. The common human reactions to feeling pushed, when the patient is feeling pushed, they're not being listened. I thought this is kind of an interesting little schema here. Their reaction is maybe anger or agitation, maybe even being afraid. There may be some oppositional kind of listening. When they're not being listened, they may be feeling helpless or overwhelmed. Have you ever been in a situation somebody's just really talking to you and and you're sitting going, but what, wait a minute, you know? I've been there. I was there just the other day. Okay. Discounting, you feel discounted, maybe even ashamed, defensive, trapped, Justifying, disengaged, these are all pretty negative things. Not understood. They don't want to come back. Why would I want to go back and get talked to like that? I'll avoid that all I can. Not heard, uncomfortable, and they're going to procrastinate and they're going to resist. But when somebody feels heard, then they usually feel understood. Oh, he's really listening to me. Oh, I feel safe here. Oh, I want to talk more. And there's our word, empowered. Oh, I'm liking this counselor. I'm liking this person. They listen to me. I feel very hopeful. I might could actually come back and work with this person. Open. Oh, I can say what I need to say. I can tell them anything. Feel comfortable. Respected. Interested. Engaged. Want to come back. Want to cooperate. Oh, yes, Miss Quartermaid. Yeah, thanks. All right. Yeah, I'll come back. We'll do this. All right? So it's a very different dynamic when patients are feeling they're being listened to. So here are some of those little techniques we've all learned somewhere along the way, but if you haven't, that's okay, because there's some techniques that are used. And the one, we see this in our, if you see anything on a movie or in tech, people love to get on mental health people, and I can't think of any good example, but this is so typical of an example, is an open-ended question as opposed to yes/no questions. What is the most difficult thing about having sickle cell disease? That's a very open-ended question, isn't it? So if you're talking with your patient, you're communicating, I'm really interested in your life, and how is this impacting you? Tell me more. How do you feel when your pain interferes with your job responsibilities? How? That word how. How do you feel? Well, how do you do? Or how do you do? That's that open-ended question. Be cautious about using why. I want to say a little something about that. We do use why, and it can be very effective. It's not a problem. But in general kind of conversation, when you're with a patient, maybe you haven't developed, remember we talked about Keith and the development of trust. If you don't have any trust or relationship, asking a why is just going to get you into trouble, because you know what? The patient may not know the why. And then you're just going to put them on the defensive. So asking a why should be saved for kind of special circumstances when you really have a relationship to work with. But using questions with what's and how's, very good little technique to remember. Now, is this easy to do? No. Now, for some of you, it may be just old hat, because you've been so trained in this and you're so good at it. Some of us, I was a nurse for a lot of years and was not good at it, okay? Because I was used to being the nurse, coming into it. I was in control, you do what I tell you to do. Memory. Something about memory is kind of interesting to me, is that our memories are not perfect, and we fill in the blanks when we're listening. If we don't catch everything, we fill in the blanks. Well, that is maybe not a good thing if we're listening to patients telling us about something that they're doing or not doing. And we start filling in the blanks, we may fill them in wrong, okay? The speaker and the listener attaches different meaning to the same statement. We've had that happen to us all the time. You're trying to negotiate something with, say, a vendor, and you say something to them, and they go off deep in, and they're like, oh, well, no, you do this. And you're like, huh? That's not what I was saying. I'm sure you've been there. There's a need for motivation to listen. As the professional, we have to make a point to listen, to sit down, get ourselves ready, and then listen. We can't be doing it if we're thinking about Mrs. Jones next door, or where am I going to go for lunch, or my car's parked out there in the poverty, not a good part of town, and I'm worried about that they're going to steal it. I mean, that isn't going to work, is it? Not going to work. We have to be motivated. And retention is lessened when we engage in some mindful listening. We did a little exercise yesterday on mindfulness. Well, we need to mindfully listen, really pay attention. All right, we have a little video. I want us to look at this first. Let's think about those words, sympathy versus empathy. And I think Shirley's going to mention this a little bit too as we get into developing relationships with patients. But there's a difference. It's slight. And I think yesterday we talked about grieving and mourning. Remember that? Slightly different in that the grieving and mourning are used a lot. Sympathy and empathy, very similar. Sympathy is actually, my friend's husband dies. And I'm like, oh gosh, and you have these feelings and you want to do something to express your sympathy. You may go to their house, you go to the funeral, you go hug them, you tell them things, all right? You say, oh, I'm so sorry for your loss. That's being sympathetic, all right? In healthcare, we can be sympathetic to our patients, and that's allowed, okay? There are times, though, when we want to be empathetic, which is the next step, and that we put ourselves in their shoes. That we then have a sense of what they're actually feeling. So we can express sympathy, but we share empathy. All right? We should have our little short YouTube-y thing. All right?
So what is empathy, and why is it very different than sympathy? Empathy fuels connection. Sympathy drives disconnection. Empathy, it's very interesting. Teresa Wiseman is a nursing scholar who studied diverse professions where empathy is relevant, and came up with 4 qualities of empathy. Perspective taking, the ability to take the perspective of another person or recognize their perspective as their truth. Staying out of judgment, not easy when you enjoy it as much as most of us do. Recognizing emotion in other people and then communicating that. Empathy is feeling with people. And to me, I always think of empathy as this kind of sacred space when someone's kind of in a deep hole and they shout out from the bottom and they say, I'm stuck, it's dark, I'm overwhelmed. And then we look and we say, hey, climb down. I know what it's like down here. And you're not alone. Sympathy is, ooh, it's bad, no. You want a sandwich? Empathy is a choice, and it's a vulnerable choice, because in order to connect with you, I have to connect with something in myself that knows that feeling. Rarely, if ever, does an empathic response begin with "at least." And we do it all the time, because you know what? Someone just shared something with us that's incredibly painful, and we're trying to silver lining it. I don't think that's a verb, but I'm using it as one. We're trying to put the silver lining around it. So, I had a miscarriage. Oh, at least you know you can get pregnant. I think my marriage is falling apart. At least you have a marriage. John's getting kicked out of school. At least Sarah is an A student. But one of the things we do sometimes in the face of very difficult conversations is we try to make things better. If I share something with you that's very difficult, I'd rather you say, I don't even know what to say right now, I'm just so glad you told me. Because the truth is, rarely can a response make something better. What makes something better is connection.
Is that it? we back on? They can hear me?
Yes.
Okay, okay, sorry. I think most of you are probably familiar with the Harper Lee book, To Kill a Mockingbird, but we never really understand a person until you consider things from his point of view, until you climb inside of his skin and walk around it. I think that really sums up that whole piece of sympathy. All right, let's talk about some of these tools for effective communication. Active listening, assertiveness communication, and motivational interviewing. Okay, we've just talked about active listening and gave you a few little tools in your virtual handout. There's actually a whole sheet of actual phrases that you can use. And you know, don't feel crazy or stupid or anything. A lot of us, we got some of this in school, but we may not have really practiced it to any great extent. So it's good to have some, you know, cues and things. And that's what I have found I used when learning to be a nurse practitioner was a whole nother world for me than being a nurse. Because I had to sit there and get that history out of people, and then I had to find out why they were in clinic that day, and then I had to find out, you know. So I remember using some of those, and man, they work. But you got to consciously use them, and many times I felt very stupid doing it. But I, over time, really learned how to use them and feel more comfortable. So the more you use them, the more comfortable you feel. Assertiveness communication. Let's see. Now, I don't know if any of you did. It was a good ways back when assertiveness training became one of those things, okay? And so many of us women went to assertiveness training, and there was a whole big discussion about assertiveness versus aggression, you know? Maybe some of us need that lesson now, but anyway, it's still very much out there, and it's still very effective. And I think a lot of people are very aware of it. But it's amazing how using iMessages is one of the most powerful communication tools somebody can use. And because we hear it all the time, where people don't use an iMessage. You make me so mad. You made me do that. Nobody makes anybody do that. But that's a way of the power struggle we talked about. So an iMessage, if we're really trying to communicate, is where we say what we are really feeling or mean, and we remove the accusatory tone, prevents the receiver from becoming defensive. You start with the I, and then you connect to an issue or event, and includes what you want to happen. And I know they use this a lot in couples therapy. And you sometimes when you're in a group or you're in something and somebody uses this, you go, oh yeah, I know what they're doing. They're using iMessages. But you know what? It doesn't offend you, and you don't get defensive. You just realize, okay, that person has expressed their feeling. I feel really upset when you do blah, blah, blah. You know, I'm not saying this, you know, I don't like it. So using iMessages can be very effective. And I'm sitting here going, where did all my other stuff go? Oh, all right. Again, I have listed some of the references. There's so much literature out there on effective communication that, all right. Are there probably no questions, huh? Any comments that people say? We're actually ahead, which is unusual. And for me,